All right, today we're working on the shoulder girdle. So whenever you have a client that comes in with shoulder pain, neck pain, if there's any shoulder dysfunction, we have to look at all the 17 muscles that attach to the scapula. Without proper scapular movement and rotation, then we're gonna have shoulder dysfunction leading to shoulder injury, especially attach the scapula into the humerus here. So that little femoral joint here is going to be messed up. So when I work with a patient, I'm looking at, in the assessment, of course, if their shoulder is elevated, if it's rotated. So I'm looking at where the shoulder is and where the pain is, and then I'm going to work with the specific muscles to either release the muscles, elongate certain muscles. So I'm going to pick and choose which muscles to focus on to actually release to get the shoulder back as close to that anatomical position as possible, right? So when I work with them, I just kind of broke it down into, when I work the posterior side, I'm working with them prone. I'm working the muscles sort of in this order and kind of testing each muscle to see which one I need to focus on. And then I'm working these muscles sort of in order with the anterior side. So when I work in the lab and show you the video of working on a patient, I'm going to be kind of working in this order, typically from largest, most superficial, down to the smaller muscles underneath, with the focus on working the muscles that I need to based off the assessment that I did prior to having them on the table. So let's go in the lab and then we can kind of show you what's going on. Okay, so now we're looking at our patient here. She's having pain in her posterior shoulder, in her left shoulder. So what we noticed on the assessment is that she has significant internal rotation of the left humerus. She has this anterior tilt and a little bit of scapular winging in the back. So she's had this chronic issue for a long time. So we're gonna go in and kind of see what is the culprit that is causing her to have this deviation. But with this deviation, of course, it's going to cause some impingement of the brachial plexus, causing most likely issues in the cervical spine, in the nerves that run down to the arm and hand. So her body's going to, of course, bring on that pain signal saying, hey, something is not flowing properly, so we're going to cause this pain. But because of the forward deviation, it's going to put a lot of strain on the posterior muscles to pull to bring her shoulder back to anatomical, causing most of her pain to be on the posterior side because the muscles are just on constant slack being pulled. But I guarantee that when we work on her anterior shoulder, we're going to really have to work on those muscles to release them, to bring that shoulder back, to do some external rotation of that humerus, to allow more of this traction of the shoulder as she rotates her humerus up. That shoulder has to actually drop down out of the socket, rotate around to prevent this pinching above here at that acromion. So how I work is I'm working with all the muscles of the scapula, as we said, but I'm working the larger muscles here that attach up to the scapula. So I'm working the upper trap, I'm working the lat dorsi, okay? And then the deltoid, and then working underneath those as well. So I can't get to the teres and the rhomboids and all that until I go through these major muscles here, okay? So first muscle I'm going to be working with, really the first two muscles on the back, is going from the cervical spine, so the occiput, and going kind of all the way down to the sacrum here. and working this kind of back line to work over these two major muscles. And when I first palpate, I like to give a little bit of decompression of the spine, kind of just coming with the palms, pushing down, pushing up. And I'm just gently pushing and giving some traction here and seeing how much movement can I get in each vertebra. Are the skeletal muscles so tight that it's holding them down in place? Is the nervous system responding negatively and kind of giving me that stretch reflex? So this kind of gives me a basis of how, I guess, intense I can work with the patient to work through the nervous system to allow these skeletal muscles to release muscles of the shoulder, but also give me some more innervation from those spinal roots into the shoulder and arm and back. Okay, so now I'm just doing some slow traction coming up that thoracolumbar fascia, giving a stretch coming up the medial side of the lat dorsi, coming up through the shoulder and really coming around and encouraging that shoulder to depress. So my thing is all about going low and slow. I want that shear force. We have all those layers of fascia in between, so we need to really pull the layers against the other layers to allow more of that sheerness to open up the fascia and really get more fluid throughout all the layers. Going this kind of effleurage and kind of, going over too lightly is not going to get down to those deeper layers, and it's not going to work with that fascia in between each muscle layer that's overlapped. All the muscles have a thin sheet of fascia that runs underneath to keep them kind of stacked in place so that our muscles aren't just kind of flipping all over the place. So we have to work with that deeper layer of fascia as well. But using too much lotion, not having enough friction is not going to give you enough of that shear force. All right, so now I'm kind of palpating on the medial side of the scapula, kind of going over and feeling are there any trigger points, restrictions, anything along the trap, but also kind of pressing down across the rhomboid major and minor as well. Again, I want to encourage the shoulder to go down. If the shoulder's way up here, I want to encourage it to go down as I'm working. So you can even move and pull the shoulder down as you're working and encourage it to go back in position. Now I'm going to bring this hand behind the back, and I'm going to see how much of a winging does she have. Okay, some people, they have so much of a pull in the anterior shoulder that their scapula is going to be way up here and super wing, where I can just literally put my hand underneath the scapula. this shows me that I don't want to work a whole lot on this anterior side. I want to get some circulation going, but I don't want to work too much, because if I work too much on that posterior shoulder, it's going to drop it down even more, which is going to cause more of a problem later on down the road and more instability. So for her, she's a little bit tight because she's kind of holding, you know, she's relaxed, but her elbow isn't dropped down fully, so she does have some tightness here. But if I kind of forcibly press it down a little bit, gently press it down, if you will, it's going closer to the table, but I don't want to encourage too much winging of that, just enough to really get down into the rhomboid major and minor and see if there's any sort of restrictions from it being so tight on slack because of that anterior pulling. And I like to do a lot of cross fiber friction along the nerve roots, because the more I can release the muscles that are in the erector group that are surrounding the vertebra, the more freedom I can give to that nerve root, which will communicate to the nervous system, more communication out to where it innervates, and those muscles are going to be more likely to relax and release instead of being guarded because of the body trying to protect the spinal cord. Okay, so now that I kind of worked the upper trap, part of the teres, part of the lat dorsi, but the lat dorsi runs under the shoulder. So like in this position, it's kind of difficult to get both attachment points from the lumbar over to here. So what I'm going to do is I'm going to bring her arm up, and I have like a little sling here, or you can bring a chair or a stool and put the arm forward. So now I have access to all of her lateral body and her torso. So working the lat all the way up here, I have much more access to do that. So working from attachment point to attachment point. All right, coming in, palpating, seeing are there any knots, adhesions, trigger points at that thoracolumbar junction. Like I said, low and slow. You're just pressing and pulling and letting the tissue move your hands versus you moving too much through the tissue. So I'm going as slow as the tissue will release from under my fingers. So again, I'm pushing the muscles along the spine away from the spine. So it's kind of like I'm digging in this little trench here, and I can actually push against the erector group and push it away. And then I'm gonna hook and I'm gonna pull along that lat dorsi, and oblique and all that, but my main focus right now is the lat dorsi. Of course, there's other muscles involved, but we're just focusing on the muscles that are attached to the scapula to allow more freedom of movement on that scapula. So right here is where it really starts to get restricted. So now I can actually follow the muscle all the way up. And it tends to be quite sensitive right under the inferior angle of the scapula. So as that lat crosses over the inferior angle and then comes up and attaches under the shoulder, then it can be quite tender in this area. So just being mindful of the sensitivity. So now that I have access to this area, now it's much easier for me to work with these muscles here. Infraspinatus, teres, major teres, minor. Coming up, like I said, under here, the attachment point of the lat dorsi. So opening that space, I'm going to be able to get more access to that area. So now you can actually start here at the posterior deltoid, right? If you follow right posteriorly to that, you're gonna land on that infraspinatus, right? And then you're gonna come down and you're gonna land onto the teres minor, teres major, and then coming over the lat. So as I'm kind of going across, I'm just palpating to see which one is most on tension, right? And then what I can do is actually get under there and actually press on the attachment point and kind of hold that trigger point. Sometimes you might feel the muscle start to kind of spasm and then it relaxes, but what I'm going for is the Golgi tendon organ reflex from the tendon attachment to the bone. celiac cross fiber down the length. And again, there's different ways to work these muscles. This is just sort of a way that I like to approach it. Because my goal is to get as much release and movement of the joint that I'm trying to affect in the shortest period of time. By working across the fibers, the muscle fibers, you're going to avoid that stretch reflex and you're going to be working more of that fascial sheath that is over top and connects it to the bone. So now here, I can actually get, depending on how sensitive they are, sometimes people are very, very ticklish. She flinched just a little bit, so she's pretty ticklish. So I'm gonna see how much I can do, but I can come under here and actually try to get under that subscap. Okay, and then that serratus goes under there as well. So if you're looking under here, you see how the serratus anterior runs underneath the scapula. Kind of hard to see here, but it runs underneath that lateral border, right? And then the subscap here also runs under that anterior surface, but you can access it a little bit through the underarm here, through the axilla. So you can affect some portion of that muscle there, and then depending on how much you can get under the scapula, you can get a small access point here under the medial side of the scapula. But I like to come under here because you see how much of that is actually exposed. So I'm coming, using my thumbs and kind of just coming down and pressing up into there and just kind of holding that trigger point. Some like to come in with the fingers and come up this way. I find that it's more comfortable for the patients to use my thumb because the thumb is wider and it's a broader surface and it's not as pokey, but I guess it depends on the size of your hand and what feels most comfortable. Just have them breathe and relax. This can be very, not uncomfortable, but it feels weird because people don't poke under your armpit in this area. So the body can kind of give a little bit of a shudder and I don't know what's going on, but then once it realizes that it's getting circulation, that it's actually helping relieve the tension, it'll start to relax and calm down. But when somebody has when their shoulder's so locked up that it's getting closer to frozen shoulder, any sort of manipulation and movement feels odd to the nervous system because it's so used to being on lockdown. It's so used to having those limitations. So that's why manual therapy is really about repetition, because you're training the nervous system. You're talking through the body, through the skin, through the fascia, to the nervous system to become comfortable with, okay, as we manipulate the soft tissue, the nervous system understands, okay, this is a positive thing. We're going to allow this and relax and release the tension and allow the muscle fibers to go back to their natural resting length, so that the joints, the bones that create the joints of the body, can actually articulate properly and go back to the way they're supposed to be sitting, so that you have that joint freedom and you're not restricting any circulation or nerves, or you're not grinding on a labrum or a bursa sac. But it's all about that tension length ratio. All right, now I want to bring the arm down, and I want to encourage that upper portion of the trap to come down. Right, so we got the upper trap, and then underneath that we have the supraspinatus, and then we have the levator scap. I'm going to work a little bit of like cross fiber up the levator scap, working across the supraspinatus, but I'm gonna work. It's easier for me, I think, to work this when they're supine, because then I can manipulate and rotate the cervical spine and the head to allow me to get more access to put this more on slack, to actually work to release this, versus them being face down. Okay. Also with the omohyoid, same thing. Working a little bit across this, but really working it more when they're supine. But right now I can get in this little triangle here, and I can work that attachment site in here and bring it up. Okay. So coming into the triangle, doing cross fiber friction, and slowly working my way up and then coming across and actually working up the trap to the occiput, right? Again, encouraging the shoulder to go down. So now I'm doing more of a pin and stretch to get the shoulder to come down, because there's still a lot of tension in the upper portion of the trapezius and in that supraspinatus. It's not happy right now. encourage the shoulder to go down. And when it starts getting warm and a little bit puffy, you know, there's a lot of circulation going there, but I can kind of feel that it's at its limit right now. So I'm going to step away from that and see how much movement she can get. But if we overwork it too much, then it can cause more inflammation, causing the body to lock down more, causing more restriction over time, and then it'll feel good now, but then in a few days it'll be so sore and lock up. So we're kind of doing a step forward, 2 steps back. So I want to go to the limit of what she has, what her body allows me to do, and then we're going to see on the next session how much further we can go. So, you know, one misconception that I see a lot of therapists try and do is fix everything in 1 hour, in one session. It took weeks, months, years for the body to get in this state of dysfunction. It's going to take much more than 1 hour or 90 minutes to fix a problem. So we have to kind of slowly work with the body and how the body wants to respond. Okay. So now, since we worked with the majority of the muscles on the posterior side, now I can actually work I find it easier to work when they're prone. Right? So working underneath the posterior deltoid, all right, the tricep long head goes under the infraspinatus and the teres minor. So we work those, and now we're really trying to work this attachment point here. Okay? So you can see how it attaches to the scapula here, right? This is going to definitely put tension on this joint of the humeral head into the scapula. So we need to make sure that this is properly on slack, also because we want to have this on slack as we move this humerus overhead. We need to have this not pulling against the border of the scapula there. So you can kind of follow the trap underneath. And just kind of press and hold at that attachment point. You might hold for 15, 20, 30 seconds, a minute. You'll feel the response of the muscle under your thumb. But you really have to go underneath of the posterior deltoid. All right, I'm gonna have her flip. And then head down.
Which way?
On the table, go toward your feet. Right there.
Friday.
So now we're going to the anterior body. Here, we have the anterior portion of the deltoid. Under the pec major, we have the pec minor that runs up. And then we have the bicep, short head and long head that attach up into the shoulder. So this whole section here tends to be on tension. We have an internal rotation here. Typically, there's a tension in the bicep from people holding, working, typing, carrying things. So typically, the length of the biceps are shortened, but especially just in this area right here, it tends to be very, very tight and pinched, pulling this forward, causing this elongation of the shoulder, and then a person has this forward lean, and as we're constantly being pulled down by gravity, the more our center of gravity leans forward, the harder the muscles have to pull in the back to pull us back up. But if we're stuck in this position and we're not going back up, then these muscles are getting fatigued, they lock up, they can't get circulation, can't get waste out, and it causes a lot of dysfunction, and over time it gets tighter and tighter and tighter, and the shoulder joint gets tighter, 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 more pressure on the labrum, more instability, and then less reach that you can move the arm, or when you do reach, it causes pain. So in order to release that, we have to really release this anterior portion of the shoulder, which is most common on like 99% of people. All right. Can you see the shoulder? First thing I'm gonna do is encourage that external rotation, right? Working the anterior, middle deltoid. Working up the bicep, short head and long head. working, really encouraging that external humeral rotation. All right. And then, because if the bicep is on tension and the person is not able to relax fully, then again, going for the shear force, contracting, pinning, pressing down with my palm, and then releasing, extending that bicep.
Stuck there. It wouldn't come down any farther.
Yeah, sometimes it's just stuck because the muscle is not going down to its natural length. So a person can be here and they're relaxed, but it's not going much farther, versus we want to get it down here. So now that we've encouraged that length, we're going to come in to access the pec major to then get access underneath to the pec minor. So I like to go broad first, because if I just start poking in there, it's going to be very tender. So I'm going to come in and kind of flatten, press, and then pull back. With male patients, it's easier to come in with the palm, but of course with females you want to avoid doing that. So I'm using kind of the broad surface of my fingers, coming in across the shoulder, coming across here, and then elongating by extending the arm. And then you can actually let gravity pull the shoulder posteriorly even more a little bit. Palpate and really get down. Like I'm palpating down underneath this anterior deltoid to really put my finger right on here. So I'm kind of pressing here, and then I'm going to do a little bit of extension. So contract, stretch tissue, hold. If they start flinching, then just shorten just a little bit and hold. But again, working with the tendinous attachment is my main goal, to release slack on the muscle fibers. lastly, we want to come up here and focus on the cervical spine, the lateral neck, and kind of pinpoint these two muscles here. Okay, the levator and the Myofascial muscle. And of course, the other muscles, or the scalenes and the upper trap here, all the cervicus muscles, all these muscles are going to play an important role. So if the head is being pulled forward, then this levator is going to be even more on stretch. The omohyoid is going to be more on stretch. So it's going to be tighter, but not contracted. Okay. Most people have this forward head posture, this text neck, looking down at phones, looking at computers. So I want to bring this head back, bring the shoulders back, bring the head and neck back, and then we'll be able to have more access to these muscles on slack so they're not being pulled so much. And you might notice your patient might be laying flat, but then their chin is way up here because they have this forward deviation. But then most of the pain and headaches is going to be in the posterior side of the neck. Occipital pain, because the muscles are just being pulled in the back, which then are going to bring the neck forward and again elongate those muscles. And to get to these muscles, you have to go underneath that trap, in between, underneath the SEM. But once I get down to those muscles, what I like to do is, like I said, if it's on slack, the more I can release that slack, the easier it is going to be to access. So I'm gonna press on the attachment here at C1, right at the end. Then I'm going to press, and then I'm going to laterally flex the neck to shorten and give some pressure on the tendinous attachment. So I'm pressing and holding, then releasing. Then you can do some like cross fiber, do some deep effleurage down, and then again going down to the next attachment, do the same thing. Press, laterally flex, shorten, hold right there at the attachment point. So this works for all the muscles that attach up to the skull, into the spine. But the point is to release that. Go into the omohyoid. Omohyoid, you can come in underneath. Being very careful with this. This is very sensitive. Okay. So this takes some kind of skill and dexterity to do this, because this is close to their throat. You really don't want to be working on pressing on their throat. So you can really access this, come across and work as well under here, but you got to be very, very careful. You know, also really working with that platysma. If somebody has this deviation, working the platysma, you know, all the muscles of the anterior neck, the SEM. But today, for our focus, is going to be on the muscles of the scapula to release, so that she can have some more range of motion and more movement in that glenohumeral joint. That's the main purpose. The more restriction, the more friction that's going to be there, the more inflammation is going to be there, the less fluid is going to be in that area, and the more cause to have impingements and breakdown of that labrum over time. So this is trying to prevent that by loosening these muscles on a regular period, and then finding where that shoulder is unstable, and then going forward and working with a osteopath, PT, somebody to work with strengthening the muscles of that area if there was some sort of injury, or there's some just imbalance based off their lifestyle and how they function from day to day. So these are the main key points that you want to look at, main muscles that you want to look at. But it's important to understand which muscles to lengthen that are contracted, and not lengthen the ones that are already lengthened to then cause more of this imbalance and dysfunction in the shoulder. And that is based off your assessment by looking at their body posture, maybe doing some movement testing, but really looking at their posture as you're talking to them, and then doing your initial scan and assessment. All right, now look at me. All right, how do you feel? Do some range of motion overhead now. Any pinching, clicking now?
It's not clicking. Oh, it just clicked.
But pain level?
Pain level, maybe like 3.
Okay. So based off the initial pain and discomfort, how has it improved? What do you feel different?
I started at maybe like an 8.
Okay.
So
From 8 to a 3.
mm-hmm. So it feels a lot more relaxed. Usually my shoulder kind of feels like it's sitting like that.
Mm-hmm.
So like it feels like it's, I don't even say it's normal, but
It's lower.
yeah, it feels like it's sitting more comfortably. No, usually up in here it feels tight too, but it doesn't feel constricted. It feels good actually.
Good. And because it's been such a chronic thing, your body's going to want to go back to that positioning.
That's what it feels like it wants to pull up.
Yeah. So the more treatments we do on it, the more it's going to understand this is where I need to be. Bringing in a few exercises using some light bands just to kind of get that repetition, so your body knows, okay, I'm used to being in this position, but we're going to encourage that external rotation, encourage that shoulder to drop down, and then with each treatment, it's going to set more into its normal positioning, which is like not your normal, but the actual like body's normal positioning.
Yeah, because when I try to stand up straight and do that, it feels like I'm pulling myself to do that, like I'm forcing it or whatever. But right now it feels normal.
Yeah, because like I said, most of us are in this contracted position where this feels normal to be forward, but then when you open it up and you're kind of tear back to zero, your body's like, this is not how it's supposed to be. Yeah. So it's just that repetition of getting that proprioception to actually understand that this is now the new normal, back in zero again. Okay. All right. Good.